Hi guys, how are you? Thank you so much for the invitation. I would love to be there, guys, with you. But thanks to technology, I can be giving this talk from here from Chile. I'm Christian Navarrete. Pleasure being here. So we're gonna discuss now about the role of confocal microscopy in our daily practice. I have no conflicts of interest. So these are the topics we're gonna talk today. First, what is a confocal microscope for those of you who are just starting? How does it help in daily practice? Other benefits of confocal, and of course, some limitations. So first, what is a confocal microscope, right? It's this very weird device that provides with these black and white images, right? But it's this non-invasive imaging device that allows for quasi-histological imaging of the skin. You get this like virtual biopsy, histology like H&E, black and white H&E images that uses this very low intensity laser, 30 milliwatts, provided by this near infrared 830 nanometers wavelength. In depth, it can go down to 200 microns. In practice, I would say I would never trust it beyond 150 microns. And has this lateral resolution, so it means two different spots resolution of 1 to 3 microns. So keratinocytes, they measure 20 microns in the upper layers and they go down to 7 in the basal layer. You're going to see a keratinocyte. And for atypical melanocytes, they're usually more than 20 microns. We say twice the size of our keratinocytes, so it's very easy to spot them with confocal microscope. And this is what you see under a confocal microscope. This is an image of the epidermis at this level, granulose layer. And you have here all these keratinocytes, so with this dark nuclei and this very hyperrefractile cytoplasm. So this is a correlation of a keratinocyte here with histopathology here. So very nice correlation. This is a hair shaft. These are just the basics, okay? So now how do I incorporate this confocal microscope into my daily practice? What are the benefits, right? So this is how I use a confocal microscope. To me, it's a second-tier non-invasive technique. So I pre-select lesions with dermoscopy, and these suspicious lesions where I can't really tell if it's benign or malignant, I use confocal microscope. So it typically improves my specificity by reducing the unnecessary excisions. So it reduces the number needed to excise. I'm going to show you our numbers. And it also increases, in some cases, sensitivity by enhancing the clinical pathological correlation. This is our experience, right? This is a paper we published just January this year. It's a prospective study from Chile. It was conducted from February 2021 to January 2024. We, of course, extracted all the data, and we used the clinical and confocal diagnosis as the worst possible. What does this mean? If somebody sent us a case as dysplastic nevus versus melanoma, we label this as melanoma. If it was dermal nevus versus BCC, we label this as BCC, right? And for melanocytic lesions to standardize, we recorded everything with the Empath DX 2.0. So look at these. These are the number of patients. We included 1,285 lesions, most in adults, 96%, and 4% pediatric patients. But still, I'm going to talk 1 second about pediatric patients. The most frequent location was the head with 51%, and the cheek was the most common location, followed by the nose, and of course, then the back. This is very typical, right? So basically for facial lesions, that was our main anatomical site. So these are the pre-confocal microscopy diagnoses, right? So most were sent as a malignant diagnosis, which makes sense, right? I was telling you, we consider the worst possible diagnosis, right? So most were sent to rule out melanoma, to rule out BCC, rule out SCC, and then a minority of cases were benign cases and other diagnoses. Maybe some of those were research. So we ended up with more than 1,200 lesions. After confocal microscopy, look at these. From 95% malignant, we moved to 39% malignant, 57% benign, and of course, other diagnoses again. Remember, this was like a prospective study, so we consider all comers, right? So now, after confocal, only 39% malignant. The most common was PCC now, second by melanoma, and third by SCC. And now benign, of course, nevus. Of course, those were the cases that switched from melanoma to nevus, psoral lentigo, LPLK, and actinic keratosis. So overall, we saved 58% of biopsies after confocal microscopy. Younger patients had more biopsies saved than older patients. That was statistically significant. And more biopsies were saved in pigmented lesions, which again makes sense because one of the most common diagnoses was rule out melanoma versus nevus. Here, we almost reached a 2/3 reduction in biopsies, and it was less for non-pigmented lesions. Same for melanocytic lesions. It was a 73% reduction versus 39% for non-melanocytic lesions. And this is also very important. If lesions were referred by general dermatologists versus oncodermatologists, reduction was much larger by those general physicians, which again makes sense. They're not so used to evaluating pigmented lesions, and confocal microscopy helped them much more in reducing biopsies. This is sensitivity and specificity and positive predictive value and negative predictive value for RCM. And you can see here for BCC, sensitivity was super high, 98%, specificity 92%. For melanoma, 100% sensitivity, but a bit lower, 78% specificity, which is very common. For SCC, lower sensitivity, but a very high specificity. And this is very interesting. When we adjusted melanocytic lesions based on the empath-DX classification, sensitivity dropped a bit to 98.5%, but specificity rose to 80%, which is super, super good. I want to now show you a dye score between the RCM diagnosis here and the histopathological diagnosis here. You're going to see here when we thought it was BCC, 96% of the time was BCC on histopathology, so it's almost a perfect correlation. With melanoma, it was only 0.5, but when we consider melanoma versus in confocal versus empath-DX 2.0 group 2 or more in histopathology, we got to a 70% correlation. Same if we group these severely atypical dysplastic nevus, all these very weird lesions together, we got a 75% correlation between confocal and histopathology, which I believe is a more real indicator of correlation more than just melanoma or nevus, right? And again, nevus, it was a 94% correlation, so super good. For SCC, there were like few cases, so I wouldn't consider this number. And for Spitzer lesions, the same. I think only a few cases. So the overall RCM to histopathological correlation was 73%, which I think is super good, right? It was 17% for malignant lesions, but 92% for benign lesions, which I think is also very good. There was a correlation with age. Again, older patients versus younger patients, we got a better correlation for older patients. For non-pigmented lesions, better correlation. For non-melanocytic lesions, better correlation. Again, makes sense, right? We're better for BCC than for melanocytics. And this is super important. For head and neck lesions, look at this, 81% correlation versus 58% correlation for other locations. Again, this is super important because I think on the head and neck, we got mostly a dichotomic diagnosis, so BCC versus nevus, or lentigo maligna versus oral lentigo. On the trunk and extremities, we have all these weird dysplastic nevus spectrum, mild dysplastic, moderate dysplasia, severe dysplasia, melanoma. Of course, again, so much variation between histopathologists. So again, I think that's why head and neck is better. And there was no association with sex. In the pediatrics group, just one word, I don't do pediatrics. I was doing the reports of pediatric patients, but again, only 51 lesions in 45 patients, and here the biopsy reduction was 88%, which I think is logical, right? The most common referral was nevus versus melanoma, and there was not a single patient where confocal was not possible, and there were no melanomas in this subgroup. So again, very small group. Some cases, I'm going to show you some cases so you understand better how does this work, right? So again, 58-year-old female, history of non-melanoma skin cancer, this new lesion on the cheek, patient was worried, physician was worried. Dermoscopy, again, not a clear, easy one. I was aiming towards a benign lesion. So diagnosis lentigo maligna, seborrheic keratosis, pigmented AK, pigmented BCC. Confocal is a 1-second diagnosis. Ring pattern. You have here the keratin field invaginations here. Keratin field invaginations, ring pattern, no atypical cells, no follicular tropism. So this was a clear cut to me. Flat seborrheic keratosis, flat soil lentigo, no biopsy in it. Contrast case, right? Young patient, she was 32 at that age, with this new flat pigmented macule on the cheek. On dermoscopy, again, here you have asymmetric follicular openings here, some anorexia pattern. It was very concerning. On confocal microscopy, you see, again, here, atypical cells. These cells are around the hair follicle here, with this, starting to have these perifollicular projections here. And this was a biopsy-proven lentigo maligna in this very young patient. The patient had surgery and she's doing very well. So differences here, right? So when you have perifollicular involvement, that's a melanoma. When you have interfollicular involvement like here, that's a benign lesion. So this is why I think for facial lesion, this is dichotomic, right? Either benign, malignant, easy. Another patient with this very, very tiny papule here, right? Is this a VCC? Is this an EVUS? Look at dermoscopy again. I'm not even sure I see the lesion, right? I don't know how we detected this lesion. But on confocal, again, 1 second diagnosis. You have this vascular tumor nest with palisading and clefting. And this is the histopathological correlation of this beautiful, very tiny nodule of BCC. Look at this great vascular tumor with palisading, with clefting, and again, a clear-cut correlation. And we got surprises too, right? Like with this lady here, 58-year-old female with this new lesion on the tip of the nose. The patient was sent to rule out lentigo maligna, and they were super sure this was lentigo maligna. I see why on dermoscopy, asymmetric follicular pigmentation. So lentigo maligna versus or lentigo, that was a differential. But the moment we put our confocal microscopy here, this was not lentigo maligna. We saw these vascular tumor islands here, these cord-like structures with palisading, with clefting, these tumor nodules here. So this was superficial BCC, right? We're not thinking about this. And the patient went and had Mohs surgery, and this is the Mohs layer showing you a superficial BCC here. Another patient, classic confocal patient we saw, 44-year-old male with this new pigmented lesion on the forehead. You can see here a solitary lesion. On dermoscopy, again, are these asymmetric follicular pigmentation, multiple colors? We were not sure. Again, is this a lentigo maligna or not? So again, differential diagnosis, lentigo maligna versus or lentigo mainly. But on confocal microscopy, it was 1 second. This is the epidermis without atypical cells. We got this ring pattern, this polycyclic dermal papilla. So this was a flat seborrheic keratosis, no biopsy needed. And then the other use we had is for pre-surgical evaluation. Again, there are many uses to see residual tumor, biopsy site identification, pre-surgical merging. But I'm going to show you now this here. How do we use it for better defining invasion, etc., right? And here we mostly use the handheld confocal microscope. So look at this lady here, 81-year-old female with this 2 centimeter irregular patch on the lower eyelid. There's a partial biopsy here. Is there an invasive component? Is there a subclinical extension? These are the dermoscopic features, again, classic lentigo maligna. Initial biopsy, melanoma in situ, right? But again, is this initial biopsy representative of this huge lesion here? And then we use confocal. So when we image this area, we have just dendritic cells, follicular tropism, classic in situ. And when we image this darker portion here, we have nest and solitary cells in the dermis. So we were suspicious for microinvasion. Also, when you use your handheld confocal microscope to scout the periphery of the lesion and see if there's some subclinical extension, you can see here all these atypical dendritic cells with follicular tropism going beyond the clinical margins towards, this is my ring tape here, my paper ring here. You see here the subclinical extension. And with this information, you know first the lesion is microinvasive, but also that you have a huge subclinical extension, and that you're going to require wider margins to achieve these negative margins, right? And this is the confocal guided biopsy that showed it was a 0.3 millimeters microinvasive lentigo maligna melanoma. And here's the correlation, the area with the atypical dendritic cells just in situ, the area with the atypical nests and nucleated cells in the dermis correlates with the microinvasion on histopathology. If you are still not convinced by all these facts, is there anything else I could do to show you confocal is a very, very useful tool in your daily clinical practice? Well, yes. If you love nature, if you want to preserve nature, we want to preserve this beautiful earth we live in, With confocal microscopy, you can reduce the carbon footprint. If we compare in all these more than 1,200 patients, consecutive patients, if we have done a biopsy in all these patients compared to doing confocal, we would have found a 56% reduction in our carbon footprint compared with the biopsies, right? So this is very good. So every time I do confocal, this is how I feel, pointing towards a greener future, right? But confocal is not perfect. It has limitations. It has a steep learning curve. You need hours, maybe months to learn confocal. It's a very expensive equipment, and there are some intrinsic limitations. That the depth of imaging is not too deep. I told you, no more than 200 microns, right? And the solution is LCOCT or any other tool that has deeper imaging depth, right? This is one of those cases where we miss the BCC. Look at this infiltrated BCC. This is the clinical photo. On confocal, no features of BCC, but you see here in OCT these hyperrefracted strands that correlate with this infiltrated BCC here in the biopsy, and all these structures were deeper than 200 microns, and there's no way confocal microscopy will see any of these structures because of the limitations, right? So what are the take-home messages? Confocal improves specificity. It also improves sensitivity, reduces the number of biopsies, especially in children. It's an excellent tool for facial lesions. To me, that's the way, it's the go-to utility, and reduces the carbon footprint. And we are all building together a better and a greener future, right? Thank you so much. See you soon.